Welcome. You're at the US Deprescribing Research Network webinar. We're very thrilled to have you here today. And we have Daniela Moga presenting today. And before I introduce her, I'm going to do some housekeeping issues for our webinar. Dr. Moga is going to talk about beyond study design and primary outcomes lesson learned from the Deprescribing trial to increase cognitive reserve. This webinar is sponsored by the US Deprescribing Research Network with funding by the National Institute on Aging. My name is Dr. Jennifer Chia, and I'm a geriatric palliative care researcher at the University of Massachusetts Medical School and co-lead of the Investigator Development Core with Dr. Ken Bookvar. Before we get started, I need to cover just a few technical issues. Due to the number of registrants for today's webinar, we have placed all the phone lines on mute to reduce audio feedback. So unless you're logged in as a host or panelist, your line is muted. However, we do welcome and encourage audience participation and would ask you to put your questions in the Q&A feature on the Zoom software. When you'd like to interact with the presenter, click the Q&A bubble icon on the bottom toolbar and type your questions in the box. If you'd like your question to be anonymous, you can check the anonymous box before sending. Hosts will acknowledge questions during the final 15 to 20 minutes of the webinar, and after the webinar, you will receive an email with a short evaluation survey. If you have any technical or logistical questions, we ask that you submit those via the chat box and select the co-host Jonathan Norton to chat privately. Please make sure you're identified either by your name or participant ID so that the host will be able to troubleshoot any problem that may come up. And I would very much personally like to extend a huge thanks to the people who make this happen behind the scenes, including Gabrielle Schiller from Mount Sinai, Jonathan Norton at Johns Hopkins, as well as Raha Shafrudi and Haley Schiff at UCSF. Thank you so much to all of you. And now let me transition to introducing you to Dr. Moga. Dr. Daniela Moga is an associate professor and Larry H. Spears Endowed Chair in Pharmacogenetics in the College of Pharmacy at the University of Kentucky. She currently serves as the Assistant Dean of Research in the College of Pharmacy, and Dr. Moga is also jointly appointed as an associate professor in the Department of Epidemiology in the College of Public Health and serves as a faculty associate with Sanders Brown Center for Aging. Dr. Moga's research focuses on using real-world data to evaluate health effects of potentially inappropriate medications, as well as developing and evaluating deprescribing interventions to optimize treatment regimens for older adults. Dr. Moga recently served as PI for a comprehensive study evaluating the effect of a patient-centered treatment optimization intervention, aiming to bolster cognitive reserve by increasing medication appropriateness. Dr. Moga was also recently awarded supplemental funding from the NIA to conduct dedicated research on Alzheimer's disease and related dementias as part of the US Deprescribing Research Network. And this study, actually the pilot study or the supplemental study, is evaluating the feasibility of a telemedicine delivered intervention to reduce inappropriate medication use to patients with ADRD. So without further ado, I'm going to hand this over to Dr. Moga, and thank you so much for being here. I'm very excited to hear this.
Thank you so much for your kind introduction. Hello, everyone, and thank you all for joining today as I present on some of the things I've learned while conducting the intervention for cognitive reserve enhancement in delaying the onset of Alzheimer's symptomatic expression study. It's a mouthful. So therefore, I will refer to it as the INCREASE study for the remainder of the presentation. I do not have any conflicts of interest to declare. The only disclosure is that the INCREASE was supported through an R01 research grant from the National Institute on Aging. And before I proceed with the presentation, I would like to acknowledge the co-PI of the study, Dr. Gregory Jaika, as well as the co-investigators and collaborators on these projects, which you can see listed on the slide. I would also like to thank our participants for their time for our study, They dedicated time for the study, and without whom I would not be here presenting today. For this presentation, I will start with a brief description of the INCREASE study, followed by some preliminary results from our analysis to date. I will then zoom a little into our INCREASE intervention and discuss some of the challenges and lessons learned during the conduct of the study. So why the INCREASE study? It was estimated that about 40% of the increase in the risk for Alzheimer's disease and related dementias, ADRD, is due to risk factors that can be addressed through preventative interventions. And these include cardiovascular risk factors, diet and exercise, or depression. One category of modifiable risk factors that have been less explored from an intervention standpoint are medications. Specifically, those that were shown to increase the risk and thus would make a perfect target for treatment optimization. Age-related changes that make older adults more susceptible to medications include decrease in kidney and liver function affecting body's ability to clear drugs, an increased permeability of the blood-brain barrier with aging, along with an increase in brain sensitivity to drugs. Furthermore, older adults are at risk for polypharmacy and prescribing cascades that can result in drug interactions and adverse drug effects. We hypothesized that the adverse effects of inappropriate medications could lead to cognitive impairment, especially in older adults at risk. And addressing the use of these medications and optimizing treatment regimens would increase cognitive reserve and would prolong the asymptomatic phase in the development of ADRD in those at risk. Our approach involved tackling the problem of polypharmacy and inappropriate medications use and finding the individualized risk-benefit balance for every older adult through a team intervention that actively involved the participant, the patient. We collected detailed information on every medication used by the participant, and this information informed the preliminary prioritized written recommendations with proposed actions for each medication. The action could involve medication discontinuation, treatment modification, either switch to a safer alternative or dose change, or treatment continuation when medically necessary. The evaluation could also include adding a new treatment if it was deemed necessary. During the intervention, the participant discussed with the pharmacist and the study clinician, and the final plan was agreed upon that was centered around the patient's needs, values, and preferences. The INCREASE study aimed to assess the effectiveness of the intervention in reducing the inappropriate medications and investigate whether the level of beta amyloid correlated with the impact of our intervention on an operationalized measure of cognitive reserve, which I will discuss in a few minutes. We accomplished these objectives by conducting a 12-month randomized trial in community-dwelling, 65 years and older, non-demented participants that were all tested at baseline through positron emission tomography, PET, to determine whether they had amyloid deposits in the brain at a level suggestive of preclinical Alzheimer's disease. This diagram provides a snapshot of the study design, and for the sake of time, I would only like to point a few key elements of the study. As I mentioned, we recruited community-dwelling older adults without a diagnosis of dementia that were taking at least one medication included on the BEARS 2015 list. Our participants were required to identify a study partner to provide supervision and drive the participants to the study visits under challenge conditions. And I will elaborate on this in a moment. Randomization was stratified by quantitative amyloid standardized uptake value ratio, SUVR, that was normalized to cerebellum as determined based on the PET scan. And we used cutoff values of 1.2 and 1.4 as recommended from the literature. Our study outcomes included measures of medication appropriateness, cognitive function, and perceived health status. Medication appropriateness was measured using the Medication Appropriateness Index, MAI, and this rates medications as appropriate, marginally appropriate, or inappropriate based on 10 criteria. And so medications that are deemed inappropriate will result in higher scores as measured by MAI. We operationalized cognitive reserve using a residual measure using sequential cognitive testing that included starting with cognitive testing under a scopolamine challenge. So participants were required to place a scopolamine patch the day prior to the testing. And then this was followed at 4 weeks by an unchallenged cognitive testing. So there were the same tests delivered again after 4 weeks, but this time without the participant wearing the scopolamine patch. We used several cognitive measures that included the trail-making tests, A and B, Montreal Cognitive Assessment, and California Verbal Learning Test. They were all used to calculate cognitive reserve, and we selected all of these because each highlighted different components of cognition. However, as primary outcomes for the study, we had the MAI, Medication Appropriate Index, and the trail-making test B, as we hypothesized that the major impact of the intervention will be on executive function as measured by these tests. All the others were investigated as secondary outcomes. I would like to mention that the study was monitored by an independent data safety and monitoring board, DSMB, that consisted of a geriatrician, a pharmacist specialized in geriatrics, as well as a trial statistician and representatives from the National Institute on Aging. We finalized data collection for the study about a year ago, and we are currently finalizing the data analysis. So I will be presenting some preliminary findings that are hopefully soon be published. We randomized 90 participants, and you can see here the flow diagram from screening all the way to the number of participants that completed study activities. 90 participants was our enrollment target, which we met, and we had 85 participants completing study activities. You have here a description of our study population. We had participants with an age ranging between 65 and 93. Our sample included 57 women and 10 non-white participants. We had about a third of the sample with preclinical AD as indicated by the SUVR value greater than 1.4 at baseline. At enrollment, our participants were taking on average of 12.8 medications that included prescriptions, over-the-counter, vitamins, and minerals, of which on average 2 to 3 medications were included on the BEER's 2015 list and were flagged. Just a couple of the preliminary results, and I will focus on our primary outcomes. Regarding our first aim to evaluate the impact of the intervention in reducing inappropriate medication use, those randomized to the intervention experienced a statistically significant and clinically relevant improvement in medication appropriateness. However, there was no impact on the trail-making test B, our primary cognitive measure. As you see here, the results I am presenting are not on our proposed measure of cognitive reserve, but rather on the trail-making test B measure under challenged conditions. And we looked at the end of study while accounting for the score at baseline. And the reason is because there were some unexpected results, and I will expand on it in a few minutes, that drove our decision to evaluate trail-making test B under challenge conditions as opposed to our a priori set measure of cognitive reserve. Our second aim evaluated the impact of preclinical amyloid burden on the study outcomes. And to achieve this aim, we conducted a stratified analysis using that cutoff of 1.4. And this analysis indicated, as hypothesized, a significant effect of the intervention on both our primary outcomes, the medication appropriateness index, as well as the trail making test B under challenge conditions in those in the preclinical AD state. And again, this was something that we anticipated in our study design. I would like to also talk a little bit about the safety of our intervention. And regarding this issue, there were no major concerns throughout the study. Our DSMB meetings were every 6 months. We anticipated that some participants would experience adverse effects related to the scopolamine challenge in particular, and they did. But all of the adverse events related to scopolamine were minor, and they all resolved at the removal of the patch. Importantly, while we had 17 serious adverse events that occurred throughout the study period, none of these were related to study procedures. And we were monitoring for the risk of falls related to the scopolamine challenge, but we had none occurring with study participation. For the second part of the presentation, I would go over some of the finer details of the study. And before we take a closer look at our intervention, I thought it would be interesting to share some of the findings from our baseline questionnaire on attitudes and behaviors around medication management. These findings are important to help us determine if our team-based approach with active patient involvement would be the optimal approach. So we will look at the responses on 3 questions out of the questions included at the baseline questionnaire. The first question asked participants whether they had regular conversations about medications they were taking with their doctor and/or pharmacist. And while participants reported more conversations on a regular basis with their doctor, I thought it was encouraging to see that 1 in 5 also discussed with their pharmacists on a regular basis. We also asked whether they reached out to their doctor or pharmacist if they had medication-related questions. And similarly, participants reported reaching out to their doctor more often than to their pharmacist. When asked about active involvement in the decision-making related to management of their chronic conditions, the vast majority responded that they wanted to be directly involved. And while we didn't necessarily use the information provided by these 3 questions when delivering the increased intervention, I find it reassuring to see that our team approach with active participant involvement is in line with patients' preferences. We also look at these results now as indicating the need for additional work into educating patients around medication management. And again, we asked more than these 3 questions, but I thought these were quite relevant to the topic of this presentation and wanted to share. Now, moving into the details of the proposed changes with the increased intervention. As I mentioned earlier, the study pharmacists made baseline recommendations for all of the increased participants, and this was done prior to randomization. These recommendations were based on the information collected at enrollment, information related to the medication and health history for each participant. And the medication history included information on the duration of treatment, indication, and whether they experienced any side effects potentially related to taking that medication. For those that were randomized to the intervention group, These preliminary recommendations were used as a starting point for the conversation during the team intervention, which will be described in the next slide. So back to this figure, panel A on the left shows that among the 602 total recommendations that were made for the increased participants at baseline, the most common class of medications with potential drug therapy problems that were identified by pharmacists were cardiometabolic agents, followed by medications for gastrointestinal problems and pain management therapy. If you look on the right side of the figure, panel B, you will see the types of recommendations that were made. Continuation of therapy with dose adjustment was the most common type of recommendation, and this was followed by therapeutic switches to a more suitable pharmacotherapeutic alternative, less risky for the patient. So again, it was based on a risk-benefit profile that was individualized to the patient. Monitoring and non-pharmacological recommendations accounting for about a third of the baseline recommendations. And when I mention non-pharmacological recommendations, the most frequently involved ones was counseling for fall prevention strategies, along with physical therapy referral, dietary and lifestyle changes for GI conditions, non-pharmacological pain management, and sleep hygiene. I would also like to point out that only 8% of the recommendations involved complete discontinuation of medications. And this speaks to the need to see deprescribing in a more nuanced manner that involves treatment optimization rather than simply stopping. Now, moving to what happened during the intervention for those randomized to the intervention group. What we see here is a diagram depicting the changes made to the initial recommendations during the increased intervention. About 2 out of every 5 baseline recommendations underwent revision through the interactive team discussion with active participant involvement. Baseline recommendations were least likely to be revised for vitamin supplements and cardiometabolic medications, or with a recommending dose adjustment or new initiation. Conversely, baseline recommendations were most likely to be revised when involving GI therapy or I guess I forgot to open all of it. GI therapy and pain management medications, or for recommended medication monitoring or discontinuation. The most frequent reasons for revisions that we recorded were either due to patient preferences or because some important information that was relevant to the participant's medical history or medication-related information was missing from what was available to pharmacists during their preliminary evaluation. Upon team deliberation, participants were willing to make the changes proposed for about half of the recommendations. Sometimes they needed to confer with their primary care provider or other clinical specialists, and very rarely they completely refused to make changes proposed in the intervention. Participants' willingness to adopt recommended changes was highest for vitamin and supplements, and encouragingly for anticholinergic agents, or for recommendations involving a pharmacotherapeutic switch. Participant refusing to adopt final recommendation changes was low, and this is very important to note, across all medications categories and recommendation type. And if you recall from our earlier slides on the results of our intervention, the intervention was successful. So this is all data from baseline, but we know that they accepted the intervention, and the intervention was successful in increasing medication appropriateness. Now, while this was exciting to see that participants were engaged and willing to accept the proposed medication changes, other aspects of the study didn't really go exactly as planned. And for transparency, I would like to share some of these issues. Specifically, our hypothesis and the a priori measure of cognitive reserve assumed that participants would perform worse or the same under challenge conditions compared to the non-challenge conditions. And as a reminder, challenge conditions were the ones where the participant wore a scopolamine patch while being tested, and non-challenge were the ones with no scopolamine being involved. So based on this assumption, we were planning to calculate cognitive reserve as the difference in cognitive scores between the challenged and the unchallenged condition, with the analysis evaluating the difference in cognitive reserve between baseline and end of study. However, some of our participants demonstrated better scores in the scopolamine challenge testing visit than they exhibited in the unchallenged test 4 weeks later. While this was non-differentially distributed across treatment groups, SUVR strata, and baseline versus end of study cognitive scores, this led to our inability to analyze cognitive data as initially planned. And that's the reason in my slides presenting the results of the impact of the intervention on cognition, we had to move from using the cognitive reserve scores into using the trail making test B under challenge condition only. Here, highlighted in green, you have some examples of trail making test B testing where participants perform better when wearing the scopolamine patch, and you see the difference is quite significant. We don't really have an explanation. An explanation remains speculative, but the study coordinator observed that several participants, like the ones you have included here, made more errors when tested without the scopolamine patch. And when an error occurs, the clock doesn't stop, but the participants has to go back and draw on the paper and continue correct the mistake they made. So that adds time. Every error adds time to the testing. Now, whether the slowness in thinking and more careful drawing while wearing the patch would explain this observation is something that needs to be further investigating. And we are trying to make more sense of this data as I speak, but I don't have an answer at this point in time. Now, speaking of the scopolamine challenge, I wanted to spend a little time discussing our focus on participant safety. One of the main risks we anticipated with the scopolamine challenge and with following this cohort of participants was the risk of falling, either due to pre-existing comorbidities or medication burden, or due to the study procedures. And to address this, we incorporated several safeguards for the duration of the study. And you see here a snapshot of all of the safeguards that were involved in the study. Some of them were planned in the design phase of the study. For instance, we did vital signs and measured vital signs at every visit. We had a clinician assessment of risk at enrollment. We required that every participant has a study partner, and this was part of the eligibility in the study. And again, the study partner's role was to make sure the participant is safe while wearing the patch. We did not want a participant wearing the patch driving themselves to the study visit. So this was part of the mandatory requirement to be eligible for the study participation. We also included referrals to PT for those that were at higher risk. And we provided educational materials on decreasing the risk of falls to all of our participants. In addition to these safeguards that were included from the beginning, throughout the study conduct, we were able to gather additional funding from NIA through an administrative supplement, and we were able to acquire gait ride and wearable technology that allowed us to do additional testing and make it even safer for our participants. So everyone was tested on the gait ride and with wearable technology to detect any potential risk factors for falls. Based on all of the available information on our study participants, we used a color-coded system to evaluate the level of risk for each participant at each study visit. And based on this, we made recommendations that range from simply providing educational materials to making, as I mentioned, referrals for physical therapy for those that were at the highest risk category. And I'm happy, as I mentioned earlier, we were happy that we were able to keep our participants safe, and none of them experienced falls related to study participation during the course of the study. So I'll switch gears now and discuss some issues that we never anticipated when planning the study, and that is dealing with the pandemic. We were in the recruitment or finalizing the recruitment when the COVID-19 pandemic hit. And so in March 2020, we had to implement several changes in response to the pandemic. And in the first phase, all the in-person, university-wide, non-essential research activities for non-drug interventional studies were suspended, including increase. And the university planned for a phased restart of research depending on the evolution of the pandemic. So you have here kind of a timeline of the changes we implemented. So during this transition, we had to modify the study protocol to allow for remote data collection while maintaining the study windows for each visit as much as possible. For instance, medication optimization interventions and active data collection on adverse events were switched from in-person to remote. And we used either Zoom or telephone based on each participant's preference and ability. For evaluations for which remote modalities were not feasible, for example, the cognitive testing, including the ones with the scopolamine challenge, what we did was to extend the follow-up until in-person visits could resume. When in-person visits were resumed, we implemented screening for COVID-19 symptoms. And in addition to that, we implemented social distancing. Masks were mandatory, as well as the use of PPE and plexiglass barriers between the tester and the participant during cognitive testing. Furthermore, we shortened the visit duration to reduce in-person contact with study staff by collecting all the information that only required reporting rather than active study procedures. We did that beforehand, before the participant came to the clinic for the in-person visit, either using telephone or Zoom whenever possible. We also implemented COVID-19 testing for all the staff and even the participants before entering the clinic, with the goal of keeping the clinic a zero COVID zone. And happy to report that we were able to do so, and we did not have any issues with bringing participants into the clinic when it was safer to do so. And I will, this is kind of my final slide, and I wanted to leave you all with some final thoughts that reflect my learning through the conduct of INCREASE. While deprescribing interventions are quite unique and nuanced, it was rewarding to see the impact we were able to make and the way our participants were actively involved in managing their chronic conditions. And as frightening as it was to deal with the unexpected and realize that as investigators, we don't always have the full control of the study implementation, it was also rewarding to see the ability of human nature to adapt. It was quite impressive for me to see the dedication and willingness on our study participants to continue to be involved in the study during the pandemic. And while it was kind of worrisome, at least for me, to think about the transition to remote study procedure in this study that was highly involved in the clinic. So transitioning to remote was truly frightening, especially with this patient population. I was impressed with how willing they were to learn on how to use Zoom and adapt to using these remote manners to stay in the study. And last but not least, for sure, conducting INCREASE gave me an even bigger appreciation of the importance to put patient safety and well-being first. And with this, I would like to thank you all for your attention, and I would be happy to take any questions that you might have.
Thank you, Dr. Moga. What a incredible study, really across the translational sort of spectrum. I think that's the first PET or amyloid data that we've seen in this series. And then of course, the medication appropriateness and then the responses from patients. And so I think it's really amazing that you were able to collect information at all these levels. We haven't seen that before. So this is the chance for the audience to ask questions. There's a Q&A bubble on Zoom, or I can also check chat if you accidentally type in there. So please begin to enter your questions. There is an option for doing that anonymously as well. While we wait for some questions to come in, I was wondering if you could just clarify, just maybe for me and others, it sounds like you started the intervention before randomization, and just, if I got that wrong, please correct me, but that you had a preliminary meeting and review with preliminary recommendations that weren't finalized until after randomization, is that correct?
Yes, so we wanted to have some measure of medication appropriateness at baseline for all of the study participants. And so this review pre-randomization really served that role. So based on, and we were also looking at it from the perspective of what do pharmacies typically see. They might not interact directly with the participants. They might see records and make recommendations based on recorded information. So we wanted to have this measure of medication appropriateness and an evaluation of medication-related problems in all of our participants. And this was done, again, before randomization, so there was no influence on the pharmacists doing the evaluation by knowing whether the participant will be in the intervention versus the control group. And so while this was done for everyone, then those that were randomized to the intervention actually consisted on the conversation and the input, from active input from the patient into what they wanted from their medication management. And the list that was made by the pharmacist was really kind of the starting point. But as you saw, there were quite a bit of changes based on input. And we have a manuscript under development now that is really focusing on this piece And the difference between pharmacists relying solely on records to make recommendations versus being part of a team and having active input from the patient, and how recommendations might change depending on what's available.
That's helpful. I'm actually interested to hear to know what happened with the control group and those recommendations.
That's coming. Actually,
I
again, for the paper we currently have under review, we just focus on the primary outcomes, but from an intervention standpoint, I really want to focus more on all of the changes that occurred throughout the study, both in the control group and in kind of like really see what were the medications that were more likely to have changes made from baseline to the end of study. So that's something that I'm hoping to be able to share soon.
But the control group didn't get that next.
No, the control group continue with standard of care. So they still, everybody in the study received some educational materials on kind of being a team member when dealing with your medication. So they could have taken that information to their primary care or the specialists they were seeing and have conversations about their medications, but the team didn't actively intervene on their medications.
Okay, great, that's helpful. So some questions came in, and we have two questions. Not all Beer's criteria drugs impact cognition. Are you planning any analysis of the different classes of drugs or by class of drugs?
Yes, that's something we are planning to look. The decision of going for any medications on the Beer's list was driven by feasibility and our perceived ability to recruit participants. We thought that if we are making the inclusion criteria very strict or like even narrower than we had, it might be impactful on our ability to recruit participants, but definitely we'll be looking at those that would be more likely to impact cognition. And that might be the reason we didn't see overall the impact on the cognitive outcomes. But again, we wanted to see whether even we can intervene and increase appropriateness overall. But yes, to answer your question, we will definitely look. We might be a little limited with regard to the power we will have, but I'm sure we will be able to at least provide knowledge that would justify additional studies in the future to focus more.
Good. And the second question from Bob Waller is, the additive effects of patients' drugs are difficult to assess, and are you able to look at additive, effects or interactions of drugs?
So in a way, the measure of medication appropriateness is trying to get at that, because what we did was for each medication, we assigned the MAI, and then the total MAI for the patient was calculated by adding the MAIs for different medications. So somebody that had 5 medications could have had the same total MAI that somebody with 1 medication, but the appropriateness level was different. So that's one way to look at it. We will definitely look and see whether we could use maybe a measure of, the additive effect of anticholinergics, for instance. But again, that's something that we did not get the chance to really delve into at this point. But great question and great suggestion. We'll definitely look into it.
Good. Kind of along those lines, and then there's a third question here. The MAI has different domains, right? And I was interested to know whether the improvement that you saw, the difference between the two groups, if you looked at the different domains of the MAI and where that improvement might have, settled in which domain.
Mm-hmm. No, we didn't look at this point, but my guess is that a lot of it came either from completely discontinuing some of the medications that were deemed inappropriate. So that would definitely lower, or the change in dose, which was quite frequently recommended, that could have been, driven some of the changes in medication appropriateness.
Okay. A question, do you have any thoughts on how patients might respond differently depending on whether or not recommendations were made by a multidisciplinary team?
I'm not sure I fully understand the question. So we had a pharmacist and the clinician. I wonder if the question alludes to the involvement of the primary care physician along with the study clinician and pharmacist. And to be quite honest, I believe it would, and you saw that several of the proposed changes for the intervention group were not accepted or refused by the participants. So the decision was, let me check with my primary care and I will decide what to do. And that's something that we will be looking into to see whether those that responded that way at the intervention, whether they made any changes. But I believe that directly involving the primary care would have been, improving maybe on the uptake of the intervention. And I'm not sure I completely, so if the person that posed the question wants to add anything, I would be happy to answer some more.
Okay, good. So while we wait for that question, did you consider using any of the anticholinergic burden scales?
Yes, again, it was, we wanted to make it more about medication appropriateness in general than a targeting intervention. We actually, the preliminary data for this study was based on a smaller scale, a shorter follow-up study that targeted anticholinergics. But we wanted to really tackle the whole spectrum of medication appropriateness rather than focusing on anticholinergics. So that's kind of my short answer to the question.
Okay, it looks like we have a clarification here for that question about the multidisciplinary team. Are patients more likely to give a positive response when the recommendation comes from a pharmacist clinician team versus pharmacist or clinician alone?
So we did not test that, obviously, and we thought that I'm a very strong supporter of pharmacist involvement, direct pharmacist involvement, and as you saw from those baseline questions we asked our participants, participants seems to be more likely to talk to their doctors, so maybe they would be more likely to accept changes if they come as recommended by their doctors. However, I'm a strong believer on what pharmacists bring to the team, and so I feel this was an opportunity for us to also educate the patient population on, the importance of getting and, having pharmacists involved. So again, without having any data to support this claim, I do believe that maybe, it would have been, if you compare pharmacist versus physician, maybe a higher impact of the physician intervention. But I think having a multidisciplinary team made a bigger impact. Again, cannot test this hypothesis, but it's just my take on it.
Great. And we have time for more questions. And of course, the panelists are welcome to ask questions as well. And while we wait, I have a couple of my own. One was about your follow-up and whether, and I know you're still looking at the data. Did you see any durable difference? I know you saw some differences at the initial, but any durable differences at follow-up later on?
I'm not sure.
In your any of your measures, your outcome measures. So, or maybe I misunderstood. It seemed like you had several follow-up time points.
So we only looked at, so we had follow-up and basically reinforced the intervention at 6 months. And then we had the end of the study was a year later. So our outcome measures and the analysis was done as a difference between the end of the study and the baseline. So we did not use at least, so it wasn't part of the primary analysis to look at anything that happened at 6 months. And we did not do we only did a scopolamine challenge at baseline and at the end of the study.
And that was 1 year?
That was 1 year, yes.
Okay.
Yes. But we collected data on medication use, so we can have a more longitudinal view on their medication taking behaviors throughout the study, and that's something that we will be looking at, as well as we collected on a regular basis data on adverse events.
Great. Really interesting that's the scopolamine challenge, which I wasn't familiar with as a test before this, that people did better on scopolamine, or at least they did worse off of scopolamine 4 weeks, and that was that was a month later. Is that right?
Yeah, that was 4 weeks later, and that was quite surprising. Again, our hypothesis was that they will perform at the same level. Again, when we looked, we allowed for a little difference as recommended by our study statistician. So we considered a relevant difference if it was more than like 50 seconds between the two, and we had several that did better by more than 50 seconds between challenged and unchallenged. And again, that was totally unexpected. And we don't really, I mean, I'm still trying to make sense of the data. It could be for some participants that, I mean, I guess with cognitive testing, you might have better days than others. So there could be that variability with the testing. But the challenge was, so the learning effect would not work because the challenge was first. So you would expect the learning effect to show with improvement on the second testing. Again, the only thing that was mentioned by the study coordinator that administered the test was that some patients really seem to rush through completing the trail making test B, especially if they did really well with the trail making test A. And so they made more mistakes while non-challenged. So again, we are speculating at this time. I think this is something that's it's quite interesting and worth investigating further to see what's happening.
Yeah, I'm wondering about learning, because so learning happens at the first administration of the test, right? And I'm just wondering if there's some opposite of learning going on that's affected by scopolamine. In other words, it's like adverse learning effects because of the presence of scopolamine. But
yeah, again, that could be. I don't know. That we actually chose to do the challenge test to begin with to avoid learning effects or to minimize the learning effect. But yes, it totally took us by surprise.
I would be interested to know if what's known about scopolamine effects on learning, and you know, maybe.
I mean, there are. I'm not aware of other studies, clinical studies that use this. We kind of used it as a, in a way, a parallel to the stress testing for cardiovascular diagnosis, and so that's kind of like a parallel we made. And there is information, obviously, on the impact of scopolamine on cognitive function, and we also thought it would be safe enough given the fact that it's available over the counter, right? So and the older adult population is using scopolamine patches, so it's kind of how we came to this measure of cognitive reserve. We were trying to operationalize it in a manner, but yes, it didn't work exactly as planned.
You have one more question, and probably time for this last one, which is, did you look at mortality, and was there a difference between the two groups?
We have information on mortality. We did not look at differences. There were none of the deaths, and I believe we had 2 participants that died were related to study participation as deemed. So with 2 events, it would be impossible to look at any effect. And that was not planned as well. I think with a 1-year follow-up, that might be hard to tease out. But definitely an important outcome to consider, and maybe for a longer follow-up study.
Yeah. All right. Well, really, thank you so much. Thank you for presenting your work, and really interesting combination of hypotheses. And you know, we look forward to engaging you again with USDen. And thank you to all our attendees who joined this webinar, and there will be a recording of it posted on the US Deprescribing Research Network website. As an attendee, you will receive a short evaluation survey by email that we hope you will fill out. And our next USDen network webinar is going to be June 14th. And our own Shelley Gray will be presenting, and that's at 2 p.m. Eastern on June 14th. So thanks again, and enjoy the rest of your day, everybody.
Thank you. Thank you so much for the opportunity.